Welcome to Bridging Healthcare Gaps. The show explores how clinicians and organizations are thinking about the care and close the gaps in our healthcare system. So today I'm very happy to be joined by Dr. Scott Hammond, and we know for, I don't know, 10 years at least. I know Dr. Hammond for a long time. And so he's long time family doctors and also now the founder of the local nonprofit organizations. So we will talk about his journey, and I think it will be very insightful. So to get started, Dr. Hammond, can
Hi.
you just give us brief introduction of yourself, your background, your experience?
Sure. Um, well, I graduated. I went to family medicine residency in the early 1980s. Prior to that, after medical school, and in those days, I did ER medicine. That was before there were specialty of emergency medicine. So I had a rather broad outlook on healthcare. The um, training for family medicine back in those days is really rather comprehensive. We were trained to do everything from delivering babies to doing hospital work, ICU work, to do your surgical assistance on all your patients, office procedures, from vasectomies to colposcopies. And so it was, really rather well trained uh, to take care of what they hoped was 80% of people's problems. And, I developed that skill, but about 10 years or somewhere between 10, 15 years after practice, I was getting quite an angst. Something was wrong. And it occurred to me, although it was in the literature, it was an epiphany to me, that I was trained in acute care medicine, but most of my work was in chronic care. And about that time, I got involved with a initiative from the state of Colorado on diabetes and was introduced to Ed Wagner's chronic care model. And that just, changed uh, my direction of my practice, and I started to uh, spend a lot of time and focus on uh, learning and delivering chronic care management.
Okay, that's like all day, right? That's when. Uh,
Oh, that was 20 years ago. Well, yeah, about 20 years ago is when I started to then really do a lot of research and projects and pilots and initiatives on really just advancing uh, care delivery through in primary care.
okay, and then what you are doing right now currently?
Well, the chronic care model was nice, although it evolved into the patient-centered medical home. So I spent a lot of time uh, developing that and promoting that. And it's a really wonderful model and very satisfying to give, really outstanding, comprehensive, continuous, care to your patients. But I think the next evolution and where I think the future is going and what I'm doing now is more root cause medicine. And that's basically called functional medicine. And instead of concentrating on the downstream effects of acute or chronic disease and treating symptoms as best you can, we now have, I think, enough technology and understanding for many conditions start looking at the root cause of the condition and intervening upstream, which, really is beneficial for patients with rather very difficult, complex problems. So I've been now consulting in functional medicine and beginning to introduce, genetics in my evaluations.
Okay, that's a big shift. So we'll talk about more about the function medicine at a little bit later. You also started nonprofit organization. Can you talk a little bit about that?
Sure, an interesting story. Uh, in the early 2000, we were going through, I'm old enough to know all these different payment reforms. And so I was going through all sorts of changes in the DRGs and ACOs and HMOs and Medicare Advantage. And I could see the change from being a physician-directed care to more corporate care. And there are some advantages of that and some disadvantages of that. And the disadvantages were that I think losing a little bit, you lose a little connection with the patient when the physician isn't really driving the treatment, whether it's dictated by evidence-based guidelines or by HM, by health plan rules or whatever. So I was complaining a lot about that. And my daughter basically said, well, if you don't like it so much, do something about it. And uh, so I said, well, what can I do? I'm just a little old family doc. And she says, well, start a nonprofit and do what you think is right. And with her help, basically bought nonprofits for dummies and put the nonprofit together. And it was called at that time, the Colorado Center for Chronic Care Management. But it kind of evolved to primary care innovation, where we were trying to do practice-based research on items that really matter to our patients. And not that, again, that were not uh, pharmacologically driven or medical device driven kind of projects, but projects that we really thought were gaps in patients' care. And developed a small practice-based network of family practices in Colorado to do some rather innovative work. Um, and it's continuing.
Okay, good. So sounds like there are three big parts you are doing and you are doing now. One is as the family doctor, you've been practicing for, you say, more than 20 years. Is that
Oh,
correct?
I've been practicing 40 years.
40 years. Okay. 40 years. And that's one big part. And then this nonprofit organization, what you are trying to do there as well. And then up to today, you are doing more on the function medicine. So let's talk about the old day as a family doctor. Let's get some insightful information there. So, as a family doctor, uh, can you share like maybe one or two like big projects you think kind of transform your clinic in the way that you take better care of your patients?
Well, that goes really back to where I basically added chronic care management to the practice, and following initially Ed Wagner's work, developed an asthma clinic and a COPD clinic and a diabetes clinic and a lipids clinic and a blood pressure clinic, all that, incorporated this new way of looking at chronic disease. Because again, acute care medicine is, you got an immediate problem, you got an immediate fix, and then you're out. And we were not trained in chronic care medicine at that time. And he had, I think, five basic modules. I don't remember them all, but it was basically, administrative, having the administrative on board with this concept because it was very different delivery of care, how you integrate with technology, care delivery, decision making, and patient self-management. And those were the best I can remember the elements of that model. And, I had to create, okay, well, what does that look like for asthma, diabetes, or high blood pressure? And when I did that, I was just really, it was just, I felt like, okay, now I'm really doing something good for my patient, uh, and not just, really providing rather superficial care in my mind.
Okay. Then how about the function medicine you are doing right now? Can you talk about a little bit more like how you see patients and do you see like good outcomes from your patients from what you're doing?
Well, then being a family doc, you are sort of the first contact and the last contact with the patient. They come in with the problem, and if you can't handle it, you send them to the specialist, and it's just, and then, if some patients start going from specialist to specialist to specialist, and they come back to me rather miserable and desperate because it's just a problem that is not fixable in the conventional world. And so functional medicine provides some hope for those patients by really looking at them through a different lens. And so, I you know, stumbled on it for personal reasons. Frankly, my wife has a chronic disease that there really is no treatment for. And so I started looking for alternatives and got into the functional medicine world and learned that. So, that's kind of how most MDs end up in functional medicine for my personal reason. And so I had a lot of patients, let's say, for example, with GI problems who were on a lot of medications and still pretty miserable with very restricted diets. And, applying the principles, I had, really great success getting them on a full diet off medications and feeling really well. And otherwise, I think they would have been, really uh, going to be uh, having a long life of just of misery. And other patients who had, incredibly difficult mental health problems that did some genetics on that really was able to let me target certain, neurochemicals that, this person had difficulties in their biochemical processing, and really turned people around who were not doing well with the conventional medicine. And so it just it, there's problems with functional medicine. There needs to be more rigor, more scientific method, more clinical studies. But there's just a boatload of research out there just sitting on the bench that can be applied to people if you do it carefully and judiciously.
So it sounds like the way you see patients right now is very different from when you are a family doctor, you see patients. So, because as far as I know, right, patient they schedule appointment to see family doctor, right? So as the function medicine, how do you see patients right now? Is that they have scheduled to see you every 1 week, or how does that work?
Well, yes, it's very different. Again, because of my personal circumstances, I'm at home as a caregiver, so I am exclusively telemedicine and really more of a functional medicine consultant. And I work with their PCP and specialist team as part of the team. But I do a very in-depth so I can't get my hands to examine a patient, so I am dependent upon my colleagues. And so, I'll do an in-depth um, evaluation online, and that's often 1.5 to 2 hours after a very extensive questionnaire, and then form a very personalized, individualized care plan for that person. And I might talk to them weekly, I might talk to them monthly. So it really just depends on, what their needs are. And it's all through email and phone and Zoom meetings. And but I basically have a program where, again, this is outside of insurance. It's sort of concierge in that it's cash basis, although it's very. I don't make my living doing this, so it's very reduced rates. Uh, but it's everyone's different, so it depends on their problem. These patients, the ones I see, are extremely complex and just take a lot of time. And actually, most of my time isn't talking to the patient; it's really researching their problem. So, using a number of medical AI programs to really give me a really comprehensive view and good differential diagnosis and ideas on root causes to attack the problem and try to come up with a treatment plan that can provide some help for these people.
So you talk about this AI tool. Is that provided by the vendor you are using? It's just part of the package they offer you?
Well, there are specific programs that are there are some specific medical AI programs out there. Some are free and some are paid. I'm using, I think, four now, um, uh, and three of them are free. So I'll just query the same question to all four of them, and then pick, and I know enough about the problem to know, what is real, what isn't real, or true or not true, and but it just gives it just helps to, not that they're simple, but to simplify complex problems and also provide some really good references that help. So I end up reading a lot of their sources, and that is very helpful and which would have taken me a lot of time to find. And so the research is really rather extensive on these folks, but once I get a plan together, and it might take me 10, 20, 30 hours to really come up with a root cause intervention. Then I'm pretty well set, know what to do, and know what tools I have to accomplish our goals.
Okay. You touched a little bit earlier, say the function medicine you are doing now is very different from you used to do as a family doctor. So I assume nowadays the primary care physician, they still not doing any of this function medicine approach, right?
No, it could be done in a primary care office, and if I was still full-time practice, I would make a hybrid practice. I think it is doable. But most docs, rather well, for personal economic reasons, you know, go into functional medicine. They leave primary care and just do functional medicine, and it's hard to blend. The demands on conventional primary care are so great that it would be difficult. And the rules and the check boxes that they have to do and the demands are just it would be very difficult to spend the time with the patient to really get down, uh, you know, to the root cause of their problems. I spend an hour each visit with my patients, and so that's just not economically possible in the current payment model. So most people are doing functional medicine are doing it on a cash basis, and there are just a lot of patients who need it because they're not getting the attention and the focus and the care that they need in conventional medicine. They basically, there's a lot of syndromes in medicine, And syndromes basically are a constellation of symptoms, and you really don't know the cause. And so they lump it into a syndrome, and then you treat the symptoms the best you can. Well, those patients end up on my doorstep, and we try to find, okay, this is not a syndrome. I can tell you why I think you have this problem, and this is what it is. And that goes back, using this just this great research in whether it's immunology or genetics or the microbiome to say, can't be sure right now because we don't have the studies, but I think this is the process that's affecting you and why. And this is how we're going to treat that. And, patients understand it. And the fact is that the model has worked. So at least anecdotally for me, I can't show you numbers, but, it's just about everyone gets better. So
So, if I understand it correctly, from patient point of view, it's proven it's better for patient's outcome, but they cannot implement that in the primary care physician because of the payment, uh, like reimbursement, how much they are getting for the clinic and for the doctor, and the time they spend on that. It's just impossible for them to implement. Is that what you're saying?
that's part of it. And I think I could have figured out a way to make it work. But I think the other part of it is that functional medicine isn't quite prime time. There's not a lot of clinical studies and trials to support what you're doing. And that's a very scary place for a physician to be. Of course, our prime directive is to do no harm. And so I don't have the evidence, clinical evidence. I might have a lot of basic science, and I'm taking a bit of a leap of faith. I might have a lot of animal studies, but animals aren't humans, and mice physiology is very different than human physiology. So, I don't blame physicians not uh, um, adopting this because you're really out on a limb, and you're experiment. I mean, a lot of medicine is experimental. I mean, will this drug help you? Well, it's really an experiment of N of one. And, do you have the genetics that's going to, or the condition that this drug is going to work for you? Well, don't know. But when you have a study of 50 to 100,000 people and you can say, well, for that cohort, it does work, and you as an individual will have to see. Well, that's a much safer place to be than saying, well, this really has not been studied, but it has good theoretical, research to say that it might help. Now, that's just not a place that lots of physicians want to be. It
Right,
takes a fair amount of courage, and it takes a patient who's willing to take that risk.
right. Understood. All right, we are running short on time, but let's talk about CCPCI a little bit. I think that's important part of your journey as well. So, are you guys doing any projects? What's going on with this organization right now?
Well, there's several family medicine practices, and basically they have an annual theme. They pick a problem that is a big gap in care and that they want to solve, a wicked problem. And so the first wicked problem was loneliness. And so the group decided, to attack loneliness and implement it into their practice of care, which was done. And a research paper was generated on this and is now set for publication. They also, have taken on other big issues. It's a lot around patient communication. So there's a model of care called goal-oriented care, developed by James Mold, and it's another way of really approaching the patient from the patient's needs. And I think it's absolutely wonderful, and patients really love it because they're heard and their needs are being really being attended to. And so goal-oriented care was, and there's a certain, it's a model, and there's a certain system that you have to implement in terms of how you approach a patient with basically four basic modules of uh, what their needs are. But that helps you then determine the right treatment for them. There's a lot of treatments out there. What's the right treatment for this person? Well, goal-oriented care helps the patient and the physician, really land on that. They're doing work on AI with communication and work with on recently started on frailty. Really big issues that are really important to about every patient that walks into the door, but not getting a lot of attention in the research world. So, it's very exciting work.
Cool, cool. So I think looking forward, like for especially for what you're doing on the function medicine and this CCPCI organization, can you share a little bit about any of those you are doing, any struggles right now? And also, second is if you move fast forward in 6 or 12 months, what kind of goal or something you want to achieve for what you are doing for both parts of of this?
Okay, can you reframe the first part of that question?
So the first part, any like things you struggle and you frustrated, you want to do, but things just not doing your way.
Oh yes, I mean it's every system has the same problem, lack of money. And yes, we struggle with having the appropriate funds to be able to do the work and support our practices and we get the statistics and get the people to put out papers. I mean, we just don't have we're frustrated with the lack of staff support and the money actually to get that staff for CCPCI. Um, uh, where I would like to be in 6 months would be to for CCPCI to get the research going would be to find a funding stream that would allow us to expand personnel to be able to support practices and do the work because that's what's really holding back the work for CCPCI. Uh, for functional medicine, in 6 months, it really would be, you know, uh, integrating AI more into the, um, research and treatment recommendations for patients, because it really is going to be, a tremendous help. So I'm hoping that, I'll be knowledgeable and skillful enough with integrating AI.
Okay, anything you struggle with function medicine you are doing right now?
Yeah, just living in the unknown. I mean, there's just so much you don't know, and even though you think you know something, we don't really, we have a very small understanding of how the human body works
Yeah.
from a cellular, molecular level. And the interactions of one, and how, the domino of the billion permutations that happen when you intervene and trying to, again, hit on the right intervention is really a struggle. And of course, I'd like to make it less costly for the patients right now. The testing is cash, the supplements are cash, I'm cash, and I'm trying to figure out a way to make it affordable for most people.
Okay, good. Thanks, Dr. Hammond. I think I can feel you are very passionate about patient care, and you try a lot of different stuff and doing a lot of different stuff. And we cover a lot of different aspects in our healthcare. I probably can invite you back. Just talk about maybe dig in a very specific topic in the future.
Sure, be my pleasure.
All right. I think if you enjoy this episode or you have any questions, feel free to leave your comment or questions, and you have questions for me or for Dr. Hammond, feel free to leave the comments below. We'll try to get answers for you. And thanks again for listening. And I'm excited to have you back with us on the next episode. All right. Thanks. Take care.